So, good evening, all the aspirants present here. This is the EDIC Part 1 crash course where we'll be going to start GI, and the speaker that we have here is Dr. Asif sir.
Yeah, thank you, Sana, for your kind introduction. So, in the gastroenterology student, I will tell you the three area is very important. You will definitely get question from this three area. One is your acute renal failure. Second is your upper GI bleeding, and yeah, the 60% question for and the pancreatitis. This three will give you the 80% question, and the few question you will get from the CLD chronic renal failure and Tania, আমি অফিসে চলে এসেছি and you call me after 8:30. I'm in a class right now. So thing is that there are 80% question you will get from this three area, and the remaining 20% question you will get from the chronic renal failure, chronic liver failure, CLD, and where CLD there are two important area. One is the spontaneous peritonitis, bacterial peritonitis, and you will get the hepatorenal syndrome. Hepatorenal syndrome is very common and very popular area for EDIC 1 exam. You will get the question from the hepatorenal syndrome. If you follow my lecture in upper GI bleed, then you will see that I have covered all this area where the question come from. Now let's start today's. My main focus in this three area, because you will get the maximum question from here. So the first question is and remember this exam you have a 60 or 65% question you will get type A, and 35% question you will get type K. Type K is the true and false answer, but the marking is like that. If you done three option right, you will get half marks, and if you get five option right, you will get full marks, and below that you will get 0 marks. But type K question actually check your depth of knowledge. Okay. So in the GI, you will get a lot of type K question from acute liver failure and also from the pancreatitis. Now, coming to the acute liver failure, N-acetylcysteine NAC is beneficial in non-paracetamol induced ALF. You can write down your answer in the chat box. It will be helpful for discussion. Intracranial pressure monitoring is advised in low-grade encephalopathy. Acute liver failure is characterized by low cardiac output and often require vasopressor support. And high positive end expiratory pressure may exacerbate hepatic congestion. And hepatocyte necrosis cause hyperglycemia. Now, please give your answer in the chat box. Yeah. So let's see. So N-acetylcysteine is beneficial in so Shrikant Koti has given this is a K-type question, so you have to answer true false manner. So first one true, then intracranial pressure monitoring is advisable for a low grade encephalopathy. No is yes, right answer. ALF is characterized by low cardiac output, often require vasopressor support. Yes. High positive end expiratory pressure may exacerbate hepatic congestion. Yes. hepatic necrosis cause hyperglycemia? No, it is false. Now let's see what is the answer given here. Then we will go for deeper discussion. So N-acetylcysteine is both effective for paracetamol-induced acute liver failure, and also the evidence says that NAC is maybe it's a good effect on the non-paracetamol poisoning. Intracranial pressure monitoring, it is not mandatory, and definitely for the low grade encephalopathy, no. In a high grade where the brain edema is there, ICP is monitoring is indicated, but invasive ICP monitoring nowadays not recommended because of bleeding risks. Then ALF characterizes a hyperdynamic state of cardiac failure, low arterial pressure because of there is a low SBR, nitric oxide production is increased on the CGMP mechanism. So fluid resuscitation is the first line, and use vasopressor you can be used if MAP is not adequately maintained. And treating respiratory failure in ALF, always keep low PEEP, otherwise there will be venous congestion because it decreases the venous return. And hepatocyte necrosis causes the hypoglycemia because it prevents the gluconeogenesis, and also is glycogen storage has been defected. So so acute liver failure, there are other area you have to understand that what is the commonest cause. If they said the commonest cause in the Western country, it is due to acetaminophen poisoning, and but in Asia, if the question is given in the Asia, then it is a hepatitis is the main cause for acute liver failure, then the paracetamol. So there will be a twist in this the commonest cause, and also other toxin causing the mushroom can also causing the hepatic failure. And among the viral hepatitis, hepatitis B is highest, then hepatitis E. Sorry, hepatitis A is the highest, then B, and then E. And sometime acute liver failure can be happen due to shock liver and Wood Cherry syndrome, other causes of acute hepatic failure in the Wilson disease, and your HELLP syndrome in pregnancy. So the etiology specific acetaminophen toxicity is the highest in Western country. So then you have to remember the criteria for a diagnosis your acute hepatic failure. So what is the criteria? Can anybody can utter these things? What is the criteria to diagnose acute renal failure? So acute
Acute
hepatic,
liver failure, King's College criteria can be
yes.
taken with bilirubin of more than 300 millimoles of hepatic encephalopathy grade 3 and 4, and prothrombin time more than 100 seconds, or INR more than 6.5, plus yes.
So yeah, it's very good. And hepatic acute hepatic failure, how you will classify it is whether it is a hyperacute, acute.
Hyperacute, acute, and subacute.
Yeah. So the basis of
On the basis of less than 7 days hyperacute, 7 to 28 days acute, and more than 7 to 28 days subacute.
very good. So now next coming to your general consideration, the CT scan of brain you have to do to rule out any hemorrhage, and second the brain edema. Okay. And you have to know the management of acute hepatic failure for acetaminophen poisoning. So what is the antidote for acetaminophen poisoning?
N-acetylcysteine.
N-acetylcysteine. Anybody can tell me how it's work?
So
N-acetylcysteine
it
replenishes the
replenishes the
glutathione storage.
glutathione.
Glutathione storage. It replaces the glutathione storage for and this glutathione is help to
Like
metabolize
NAPQ.
active metabolism of the paracetamol. What is the name of active metabolite? Just you utter the
NAPQI.
MAPQI, yes. Full name?
N-acetyl para aminoben.
Anyway. So now the question might come regarding the King's College criteria for liver transplantation. So anybody can tell me the criteria for liver transplantation? So when there is a fulminant hepatic failure, there is a King's College criteria. Basically acetaminophen induced disease or non-acetaminophen induced disease like your hepatitis. So acetaminophen induced disease when there is a pH is less than 7.30 or prothrombin time is more than 100 seconds or your creatinine is more than 3.4 and grade 3 or grade 4 encephalopathy. But nowadays it has been taken instead of prothrombin time, they are taking that your INR. So if INR is more than 3.5 or more persistent more than 4 and pH is less than 7.30 or you have a grade 3 or grade 4 encephalopathy, then if it is a case of acetaminophen poisoning, then you have to think about your hepatic transplant. In non-acetaminophen induced disease, again, the prothrombin time is more than 10 seconds or the age is less than 10 or more than 40. And then you have a etiology of non-A or non-B hepatitis or duration of the jaundice before onset encephalopathy more than 7 days. Then these are the criteria, bilirubin more than 18. These are the criteria for your liver transplant. So for liver transplant, King's College criteria you have to remember. Now next question is the variceal bleeding, immediate mortality estimated 2%. This is also K-type question. Portal hypertension is the most common cause. Terlipressin may be beneficial in reducing bleeding and broad spectrum antibiotics should be given acutely and transjugular intrahepatic photosystemic shunt or liver transplant may be considered in severe variceal bleeding. So anybody? Yeah, let's see. So immediate mortality to 2% is T. Okay. Then portal hypertension is the commonest cause. Okay. Terlipressin may be beneficial, reducing bleeding. And broad spectrum antibiotic. Okay. So let's see. हमारे कंप्यूटर जी क्या बोलते हैं? Yeah. So the mortality is around the mortality is around 8%, and 6-week mortality is around 20% in severe upper GI bleeding. So please remember that this variceal bleeding mortality is high, and portal hypertension, yes, it is associated as a cause, but it is not the commonest cause. And tralipishin reduce flow of splanchnic venous congestion, and therefore it reduces the bleeding. Broad spectrum antibiotic has reduces the rebleeding and the mortality in a cirrhosis case, and TRIPS procedure or even liver transplant may need to consider in severe variceal bleeding. If it is due to the variceal bleeding, then TRIPS will help to reduce the mortality. So coming to your GI bleeding, just a minute. Just a minute. Give me one minute time. So, what is the commonest cause of variceal bleeding? Anyone? So, upper GI and the lower GI, it's demarcated by your ligamentum teres. If it's above, the bleeding is above the ligamentum teres, then it is a upper GI bleed. Means it is from the esophagus, stomach, or part of the duodenum. So, what is the commonest cause of upper GI bleeding? Anyone can volunteer.
Acid peptic.
Duodenal
peptic
ulcers.
So, non-variceal bleeding is the
non-variceal.
commonest cause. And then your variceal bleeding. So, acid peptic disorder is the commonest cause. That's why the second answer is false. And variceal bleeding is reduces by tolipration. Yes, it causes congestion. And regarding the broad spectrum antibiotic, there is a doubt. Why doubt? If it is a variceal bleeding, ascites is there, then broad spectrum antibiotic is reduces mortality by reducing the rebleeding and the prevent the infection. But in a non-variceal bleeding, antibiotic has no role. Okay. So management of the variceal bleeding, resuscitation, the hypovolemic shock. Here, the hypovolemic volemia is because of the bleeding. So it is recommended for you intubate the patient, and you can start with tralipressin or octreotide, and prophylactic parenteral antibiotic if it is a variceal bleeding. And upper GI endoscopy is the treatment. If you have no endoscopy facilities, then for the timing, you can use your Sengerstecken Blackmore tube. And for bridging therapy, you can do tips of Brato, BRTO. And there are few questions come from your Sengerstecken Blackmore tube regarding you have to know the how many lumen is there and what lumen for what purpose, and how much air it will give in which balloon, which one you will first blow to create a tamponade, and how long you will keep when you will release. Everything you have to know in details. So Sandstecken Blackmore tube is it's a like your Foley's catheter, but it has a 3 lumens and 2 balloons. One is the esophageal balloon and other is the gastric balloon. Gastric balloon is a high volume, is around 500 ml, or esophageal balloon is a low volume, around 100 ml. First, you have to, and the central lumen is on the tip. So first, you introduce it in the stomach. You check the correct position, whether it is a tip is in the stomach or no, stomach or not. And by just checking you are checking Ryle's tube, you will do, and then you inflate the balloon. You're sorry, you inflate the balloon. Yeah. So you inflate the balloon first. You inflate the gastric balloon, then you pull it, and when it's stuck in the lower esophageal junction, then you will inflate the esophageal balloon, and you have to keep it tight, and you have to fix on the forehead, and you have to put some weight on it, and every 4 hourly you will release for 10 to 15 minutes to prevent mucosal injury, mucosal necrosis. Okay, so the management of upper GI bleed. If you ask upper GI bleed, how will you manage? First thing, whether your patient is hemodynamically stable or unstable. First, you establish the IV line, secure the AB's airway breathing circulation, and obtain for the laboratory data. Do a ABG, hemodynamic let's check the hemodynamic instability. Okay, if the hemodynamic instable, then do a intubation, and plan for CT angio. If hemodynamically stable, then your plan for your endoscopy, and if it is a variceal or non-variceal, if it is a non-variceal, then you have to start the PPI infusion, and keep your hemoglobin target is more than 7, and as early as possible you do the endoscopy. And in endoscopy, if the variceal bleeding, you can do banding or your glue treatment, or if it is a non-variceal bleeding, then you can use the glue, or most of the time non-variceal bleeding, it is stopped by when you continue the infusion. And second thing, you have to do the embolization, either by your interventional radiologist will do, or endoscopically you can do the embolization. Next question regarding the sense taken Blackmore tube. So, बात करते is we have already discussed. So the option is 80% of the patient will rebleed once the balloon is deflated. Yes or no? Then it is effective at controlling torrential bleeding from the for esophageal gastric varices. It has 3 lumen. Insertion 55 centimeter mark at incisor indicate that gastric balloon position below the gastroesophageal junction, and the esophageal balloon must be deflated every 6 hours. So already few points we have discussed. So answer is up to 50% patient will rebleed following SBT deflation, not 80%. If it is 80%, then it should not be included in that management pathway. So that's there. And sense taken Blackmore tube is effective controlling torrential bleeding, yes, in a gastroesophageal varices. And SBT has 3 lumen, yes. One is one is for esophageal balloon inflation, one is gastric aspiration, other is gastric balloon inflation. The position of the SBT 55 centimeter from the incisor position will be below the gastroesophageal junction, yes, but you have to always check by either radiologically or by your how you do clinically in the Ral's tube. The esophageal balloon SBT should be deflated every 4 hours, 15 minutes to reduce the potential mucosal damage. One thing, can you anybody can explain what is the prognostic criteria? Is there any score for prognosticate the upper GI bleed? And what is the name of this scoring? So it is important because it may be come as a question in the K type. Okay. Now coming to the regarding the surgical resection of the esophagus, lumbar epidural is likely to be beneficial. Fiber optic scope should be available to confirm correct double lumen placement. Respiratory morbidity is high in postoperatively. Non-invasive ventilation is a early postoperative period, absolutely contraindicated. Acute onset fast atrial fibrillation at 3 to 7 days postoperatively may be hard development of the anastomotic leak. Now, why I'm putting this question, because sometime you will get some atypical question from in your syllabus because of this what I say this is from the GI. So 20% you will get from the other area. So lumen of epidural, whether it is beneficial or not. The thoracic epidural, initially we thought it is a epidural on the perspective of analgesia, so improvement come, and but it has also some side effect, and it needs skill expertise. So that, and because of development of the PCA pump nowadays, thoracic epidural is not a good fashion for use as a pain control. But in our residency time, we have seen lot of people do the thoracic epidural for the VAT surgery and for thoracotomy and also for the esophageal operation. But nowadays it is not very much popular. And the next question was fiber optic scope available to confirm the correct double lumen tube. Yes, always you have to have the fiber optic for the placement of DLT. And DLT is those who are non anesthetic student over here. DLT is a double lumen tube. It enters the both the in the carina, both the right and left bronchus. Okay. So DLT is usually we give when we give one lung ventilation, like we want to collapse one lung. It is commonly used for the thoracotomy or operation in the mediastinal structure, because when there is a necessary to collapse one lung, where the operative side lung, so it has a two lumen. There is a again there is a two lumen, and there is a three balloon actually. Sorry, two balloon. One is the one balloon in the your left bronchus, another balloon in the trachea. So suppose when you are placing the tube in the in the lungs, then it entered the left and right bronchus. So not left and right bronchus, actually it is in one opening on the trachea and other opening on the left bronchus. Okay. Or you may find the right bronchus wala tube also is there. So if you want to put the left bronchus one. So suppose you imagine that you have inflated the left bronchus tube and you have inflated the tracheal tube and you are entering the air from the opening in the carina. So it will enter the right one because left bronchus is blocked by the balloon, or right bronchus is open and the air will go to the right side. Similarly, if you want to collapse the right lung and you're trying to inflate the left lung only, then you just change the tube connector. You just put the connector on the right left bronchus wala and you inflate the balloon of left bronchus. So only there will be left bronchus ventilation will done. Understood? Hello? Have you
Yes,
understood
understood.
DLT physiology? I'm asking those who are not seen in the bronchoscope, not seen in the real life, the document tube. So it is for their knowledge. And you can check this image of the development tube in the Google. You will get good knowledge, and you also can check the video. Anyway, so that's why the bronchoscopy examination is very important. Then comes to your third option, the respiratory morbidity. High post-operatively, yes, respiratory morbidity following esophagectomy is common. This patient require critical care readmission because you are doing the mediastinal operation. Mediastinitis is very common and it causes the cardiac complication, and also if there is a leak, it's caused mediastinitis where the high mortality. And why it is important that third option, the non-invasive ventilator early postoperative period, absolutely contraindicated. Remember in the EDIC exam, wherever it's given absolutely, that is a false answer, because in critical care there is nothing called absolute. Okay, only there are few absolute contraindication for thrombolysis in an acute MI patient. And so initially it was thought that non-invasive ventilator will increase the pressure of the esophagus and the gastric, and due to aerophagia, which may cause perforation or leakage. But it has been well proved that no such things happen. So nowadays you can use the BiPAP or CPAP in a patient post-operatively, especially in the esophageal surgery. But you have to keep the IPAP is very the moderate or lesser amount. So acute onset of the first atrial fibrillation 3 to 7 day post-operatively may help development of the anastomotic leak. Yes. Why? Because if there is a leak, it causes the mediastinitis, and the mediastinal, what are the structure? One, the lung and the heart, and it causes the increased sensitization of the heart. So there might be a develop atrial fibrillation. So acute onset first atrial fibrillation always is a indicator for anastomotic leak. Just give me 1 minute time. Somebody is waiting for me. Chen, yeah. So next question is in relation to classification of acute liver failure, which is true. The O grade system classification: acute liver failure, hyperacute, acute, and subacute, depending on the time from jaundice to encephalopathy. Sorry, question kothay? This is the answer, sorry. So regarding the, what is happening? Yeah. In relation to classification of acute liver failure, already we have discussed O-grade system classification, ALF, hyperacute, acute, subacute, is defined acute according to O-grade system when jaundice and encephalopathy occur less than 1 month, hyperacute onset is less than 1 week after jaundice, and the Bernoulli system classification ALF as a acute and subacute, and Japanese system classification ALF into fulminant and subfulminant category. So you have to know all the your category of all the classification system. So Ogre system classification ALF hyperacute, acute, and subacute true, and less than 1 week, less than 1 month, less than 3 months, depending upon time of jaundice and encephalopathy. Ogre system ALF acute is 7 days to 1 month. Ogre system hyperacute less than 1 week. The Barnway system of classified ALF is a fulminant 1 to 2 week from the jaundice to encephalopathy, and subfulminant 2 week plus. Japanese system of acute liver failure fulminant is split to acute fulminant or subacute fulminant depending upon the jaundice to encephalopathy. 0 to 9 days, 9 days to 8 week is the subacute fulminant. Then latent onset period 8 to 24 week from the jaundice to encephalopathy. So next question is regarding the alcoholic liver disease. 30% of the cirrhotic patient develop hepatorenal syndrome within 1 year of diagnosis. 1 UK unit of alcohol content 20 to 25 4 gram ethanol. Patient may present warning encephalopathy. Ethanol metabolism cause accumulation of the lipid in the liver, and infliximab TNF alpha inhibitor is useful preventing hepatorenal syndrome in severe acute liver disease. Let's see the answer. So patient with advanced cirrhosis or ascites which may cause by alcohol at high risk for developing hepatorenal syndrome. 18% develop hepatorenal syndrome within 1 year. Up to 39 develop hepatorenal syndrome within 5 years. So hepatorenal syndrome, I already told you that it is one of the very popular area for EDIC exam. So please read hepatorenal syndrome and the spontaneous bacterial peritonitis in CLD cases. So 1 UK unit alcohol content 10 to 12 gram of ethanol. Typical pint of beer content 2 unit. Bottle normal strength beer 1.5 unit, and glass of wine 1 to 3 unit depending upon the size. Ethanol intake XX 40 gram per day in men and 10 to 20 gram per day in women is associated with increased relative risk of developing liver disease. So 1 unit UK unit contain 10 to 12 gram ethanol. So 1 beer is 1.5 unit, means 1.5 means is around 15 gram. So boss 2 बियर से ज्यादा मत पिया करो, तो आपका लीवर खराब हो जाएगा. So patient with alcoholic liver disease may present warning encephalopathy, nystagmus, ophthalmoplegia, ataxia, and confusion secondary to thiamine deficiency. Yes, the acute liver disease is divided into histological alcoholic liver disease divided into 3 histological type, which all coexist the same patient. Ethanol metabolized cause accumulation of the lipid in the liver cell, steatosis, that means fatty liver. 90 to 100% occur in heavy drinker and resolve within few months of alcohol cessation. Ethanol metabolism can also generate oxygen pieces. This neoantigen which cause hyperinflammation of the alcoholic hepatitis, this inflammatory response may be mild or lead to full-blown multi-organ failure, and prolonged hepatocellular damage result in liver fibrosis and hepatocyte destruction. The cause of hepatic function decline, portal hypertension due to disrupt in the liver blood flow, and ultimately cirrhosis. 8 to 20% heavy drinker will develop cirrhosis. So last option was Infliximab is useful preventing hepatorenal syndrome in alcoholic liver disease? No. So infliximab is a treatment of hepatitis B. Serum level of tumor necrosis factor raise alcoholic liver disease, alcoholic hepatitis, particularly in severe alcoholic hepatitis. Steroid are recommended, demonstrate short-term survival benefit, side effect of the steroid, risks of GI bleeding, potential increased risks of sepsis, and inhibition of TNF alpha with monoclonal antibodies like infliximab or etanercept was found to increase mortality in alcoholic hepatitis. However, pentoxifylline, the oral TNF alpha antigen, has been associated with reduced hepatorenal syndrome risks, may be considered in severe alcoholic hepatitis in patients who cannot receive steroid. Okay. So upper GI bleeding again regarding the endoscopy, gastroduodenal erosion are the most common cause of acute upper GI bleed. The Rocal score predict re-intervention and mortality of pre-endoscopy. The modified Glasgow score predict the bleeding risks and need for endoscopy. Endoscopic adrenal injection along the treatment of choice of non-variceal bleeding or ulcer. High dose proton pump inhibitor recommended post endoscopy if bleeding is present. So come to the answer. So gastroduodenal erosion is responsible only 8 to 15% of acute GI bleeding. Peptic ulcer disease most common cause 35 to 75% of the upper GI bleeding. Rocal score predict the intervention and mortality of post endoscopy. Here question was pre-endoscopy. So that's why it is false. The modified Glasgow score or your Belfort score predict bleeding risks and need for endoscopy. The National Institute of Health and Care Excellence NICE UK guideline recommended adrenaline alone should not be used as a monotherapy of non-variceal or ulcer injection. Adrenaline may be used with mechanical clip or thermal coagulation and fibrin injection of the ulcer. Now, proton pump inhibitors should be given patient on the non-variceal upper gastrointestinal bleeding. Those stigma of recent hemorrhage show at endoscopy. The acid suppression is not recommended before endoscopy unless endoscopy is likely to be delayed. So, what actually proton pump inhibitor does, it reduces the rebleeding by reduces the erosion. Severe acute pancreatitis. Come to the pancreatitis. Aggressive fluid therapy may be offer little benefit after first 24 hours of the treatment. Broad spectrum antibiotics should be started prophylactic. Contrast enhanced CT scan is warranted in all patients within 48 hours of diagnosis. Early enteral nutrition recommended. And stable patient with infected necrosis, surgical endoscopic intervention should be undertaken within the first week. So whatever the recent advance RCT or recent classification and the management change regarding the fluid resuscitation of the pancreatitis, regarding the diet, and regarding your exploratory laparotomy, what are the evidence, recent evidence, you have to read all these things before appearing your exam, because it is another area where you will get definitely one or two questions. So severe acute pancreatitis, aggressive fluid therapy within first 24 hours, yes. Then you have to go for the de-resuscitation fluid. So it has been shown that the fluid is one of the main treatment of resuscitation of pancreatitis, but the evidence says that if you give too much fluid, it will increase the mortality because it produces the capillary leak and it produces interstitial edema of the lungs and also in the peripheral edema. So first 24 hours, you be liberal about the fluid resuscitation, but at the same time, de-resuscitation of fluid is very important. Use of routine empirical antibiotic? No, not recommended for fast 7 days antibiotic unless you are getting the infective marker or culture positivity, because it is a inflammatory disease and it causes the necrosis. Therefore there is a fever, and so it is a non-infective. Initially first 7 days is a non-infective. After that the translocation of the bacteria has happened. That's why there is a patient might be landed up to sepsis. If you are not you can prevent this translocation by giving early enteral feeding. So next on the contrast enhance to CT. Actually, the then again come to the question of the etiology. What is the commonest etiology for the pancreatitis? It is a gallstone pancreatitis and alcoholic pancreatitis. Then alcoholic pancreatitis. Then there are hyperlipidemia. Then there is a viral hepatitis, viral pancreatitis. There are traumatic pancreatitis. Lot of cause. So the USG is the first investigation you have to do, and if the symptom not resolved or markers not resolved, then you can do CT, but it is not recommended earlier. It is after 72 hours or 48 hours. Early enteral nutrition is always recommended in a pancreatitis patient, and it prevent your translocation of bacteria. It prevent your microbiota in the GI tract. Stable patient with infected necrotic pancreatitis, surgical, radiological, endoscopic procedures should be delayed for more than 4 weeks to allow liquefaction of the content and development fibrous wall around the necrosis. Early intervention associated greater mortality. So early in a stable patient, if there is a infective necrosis there, surgical or endoscopic decision, you have to wait for the resolving. No intervention in the first week of acute pancreatitis. Now coming to the transjugular intrahepatic portasystemic shunt tips. So tips, it is a percutaneous formation of the tract between hepatic vein and intrahepatic portal vein, and is indicated in severe encephalopathy. Portasystemic gradient less than 12 mm is deemed to success following tips. Shunt stenosis is uncommon. Hepatic encephalopathy is unlikely following tips insertion. So tips, one of the common area where you might get question in the your part 1 and in part 2 also in your imaging table. So the tips is percutaneous formation of the tract between hepatic vein and intrahepatic segment of the portal vein. It is done to reduce portal venous pressure and portal hypertension and decompensated liver cirrhosis. Severe encephalopathy is absolutely contraindication for tips. Accepted indication include varices with refractory endoscopic or medical management. There is a refractory bleeding and hepatic pleural effusion or ascites. Photosystemic gradient less than 12 mmHg following tips, immediate control of variceal related bleeding. If varices is there, it have a good success. Stenosis in the stone thrombosis can happen. It is not very uncommon. It's a common thing. So after tips placement, you have to keep some anticoagulant or maintain INR more than is around 2, which reduces the chance of thrombosis. Hepatic encephalopathy is quite common after TIPS because it is bypassing the hepatic metabolism. So lot of ammonia entering from the gut to the system. So it causes hepatic encephalopathy, and so you have to do the medical management of hepatic encephalopathy. Regarding liver transplant, so survival at 12 months after liver transplant, acute liver failure approximately 65%. The mortality rate which is waiting for liver transplant approximately 30% in first year. Most liver retrieval are performed in category 1 to donation after circulatory death donor. The operation technique utilization vena cava preservation negates a need of veno-venous bypass. Perioperative thromboelastography may so increase LY30 and LY60, lysine time 30 and lysine time 60. Let's see the answer. So 1 year survival following liver transplantation for acute liver failure is approximately 60%. This less than following the transplantation of the chronic liver failure. So data from the United Kingdom between April 2010 to 2021, 11. So the 1 year post-registration transplant list, 12% patient has died and had been removed from the list due to clinical deterioration. So what was the, it is 30%? No, it is less than 30%. Then third question was most liver retrieval performed in category 1 and 2 donation after circulatory death. This is the evidence in 2012 to 13. There was a total 825 organ donation who donate their liver for transplant, 640 donation after brainstem death, and 185 circulatory death. And circulatory death donor can group by your Maastricht classification. The liver and the lung transplant can currently only taken in a control donor. Control donor means category 3 and 4. So Maastricht classification you have to check, and this is known as, what is that? The operative technique utilization vena cava preservation negative need for veno-venous bypass. This is known as piggyback technique. Advantage of this technique include hemodynamic stability and negotiation of the need of veno-venous bypass. So this is the Maastricht classification, donor status and control and uncontrolled donor. So 1 is dead on arrival to the hospital. 2 is unsuccessful resuscitation. 3 is waiting cardiac arrest. 4 is cardiac arrest after brain death. 5th is cardiac arrest in hospital, inpatient. So these are the classification of the donor, and this 3 and 4 is a control donation, because waiting for cardiac arrest means patient is sick. You have given the you know that this patient is going to death, or class 4 is already there is a brain death you have declared and you are waiting for the cardiac arrest, or the cardiac arrest happen after brain death. So these two can be you can call the control, because you have a time and you can reorganize your team for organ donation. Next, acute pancreatitis, Atlanta definition 2003 described 2 category of the severity. So the all the classification and the prognostic score you have to remember in the acute pancreatitis. Serum triglycerides should be obtained in absence of gallstone and alcohol history. Serum amylase is always raised in alcohol-induced acute pancreatitis. Predictive score systems such as Glasgow score, bedside index for severity of acute pancreatitis, biceps are limited prognostic value, and corticosteroids should be given part of acute management. Let's see. Atlanta criteria in 1993 described two categories, not in 2013. 2013 induced third category, that moderately severe, which is categorized patients of transient organ failure and local or systemic complication. Then you have the serum triglyceride. Yes, you have to do the serum triglyceride because the first is the gallstone, second is the alcohol, third is the hypertriglyceridemia. And serum amylase is always raised in alcohol-induced pancreatitis. No. The diagnosis of acute pancreatitis mostly established patients of 2 or 3 of the following criteria: abdominal pain. Serum amylase is the more specific for serum lipase is more specific for the acute pancreatitis, and lipase should be greater than 3 times of the upper limit. And the CT abdomen, serum amylase usually raised within few hours of the onset of acute pancreatitis, return normal within 3 to 5 days, but may remain normal alcohol-induced hypertriglyceridemia-induced pancreatitis. So predictive scoring system for acute pancreatitis, the most cumbersome, lack of accuracy if measured within 48 hours following admission, and steroid are potential cause of acute pancreatitis, thus avoid in pancreatitis unless specific indicated, or other condition that may associated with the pancreatitis. Now, considering the jaundice, it is clinically detectable when serum bilirubin exceeds 20 micromole per liter. Sepsis can cause perihepatic jaundice. Conjugated bilirubin appear in the urine, may occur following episode of hypotension on critical care, and stool are often pale and urine dark in biliary obstruction. Let's see that it is 5 minutes, 10 minutes. It is clinically detectable when serum bilirubin exceed. No, it is more than when it is more than 50 micromole per liter. Perihepatic jaundice, yes, liver capacity process bilirubin is excess, usually due to excessive breakdown of the heme subunit of the hemolysis, and unconjugated bilirubin is elevated in perihepatic jaundice. It does not present in the urine as it is water soluble, not water soluble. In contrast, conjugated bilirubin is water soluble, present in the urine. In hepatocellular jaundice may occur critical care due to liver ischemic injury following hypotension due to any cause, and it is usually associated with marked elevated transaminase enzyme, especially AST and ALT. Post-hepatic jaundice caused by biliary obstruction result pale stool and dark urine because the conjugated bilirubin, which is in the water soluble, been excreted through the urine and causing dark discoloration. Regarding the GI bleeding in perforation, again, Beerheff syndrome is acute upper gastrointestinal perforation, free gas under diaphragm. On the chest X-ray, only present 50% cases of interperitoneal perforation. Peritonism may be absent in patient taking corticosteroid, and colonic distension in pseudomembranous colitis may be decompressed with colonoscopy to prevent perforation, and degree of sepsis seen post GI perforation is depend on anatomical location. Next, see. So first one, Beerheff syndrome is cause upper gastrointestinal perforation. Yes. what happened? The syndrome means rupture of the esophagus usually occur left posterolateral aspect of the distal esophagus and recognized cause of GI perforation. It occurs due to increased intraluminal esophageal pressure due to vomiting. Then your free gas under diaphragm chest X-ray only present 50% cases of intraperitoneal perforation is false. The free air diaphragm will be visible or erect X-rays around 80% cases intraperitoneal perforation, marking erect chest X-ray useful diagnostic to suspected GI perforation. Then question is peritonism may be absent in patient taking corticosteroid. So peritonism may be absent patient with GI perforation who receiving corticosteroid, large dose sedative agent, and obvious OBS and elderly patient. Colonic distension false because there is no evidence treating of chronic distension seen in pseudomembranous colitis with colonoscopy. Rather, in pseudomembranous colitis, you do not, it is recommended not to use colonoscopy because it increases the chance of perforation. Pseudomembranous colitis is normally treated successfully in the conservative measure alone, but toxic megacolon development may require surgery to prevent perforation or achieve sepsis source control. So Clostridium difficile is the commonest organism which cause the pseudomembranous colitis. If there is a pseudomembranous colitis, the treatment of choice is vancomycin oral tablet or metrogil. The degree of sepsis required with the site of perforation, uh, stomach and duodenal fluid fairly sterile, but it is acidic, so it causes more burn rather the infection compared with the high bacterial load that occur in the fecal peritonitis associated with distal small bowel or large bowel perforation. The liver function test abnormality albumin is usually marker of synthetic liver function in critically ill. AST is more specific in the liver injury than the pure ALT. AST primary enzyme raise in the cholestatic liver disease. Normal range of serum ammonia is 15 to 45 microgram per DL, and prothrombin time is indirectly sensitive test of liver synthetic function. Let's see. The albumin is a negative acutely phage marker, thus fall in the critically ill patient. However, chronic liver disease low albumin is a marker of pro-synthetic liver function. So in the acute case, the albumin has not much role. So low albumin means it is not that the liver synthetic function is gone. Next, your AST or ALT, the cytoplasmic hepatic enzyme ALT is more specific for liver than the AST. The enzyme AST is present in the skeletal muscle, myocardium greater degree than the ALT. So ALT is more specific for your liver injury. So So AST is primary enzyme raise cholestatic liver disease. So this is the alkaline phosphatase is the primary enzyme for cholestatic liver disease. Raised transaminase such as AST, ALT more suggestive of hepatocellular disease. Then the duodenal, the normal range of serum ammonia is your 15 to 45. Prothrombin time is indirectly sensitive test for liver synthetic function, absence of vitamin K deficiency. PT is sensitive and prolonged by low level of the factor 7 is seen in the reduced liver function. Prolonged PT associated with increased mortality in acute and chronic liver failure. Next, acute alcoholic cholecystitis. So this inflammation, gallbladder, presence of gallstone, acute acalculous cholecystitis inflammation of the gallbladder in patients of gallstone to nahi ho. This is not itself because it is acalculous cholecystitis, they said. The most common in women after trauma or surgery. Serial ultrasound surveillance of acute acalculous cholecystitis should be considered trauma patient and high injury severity course. Cholecystectomy should be undertaken caused by antiphospholipid syndrome and systemic lupus erythematous, and mortality of untreated is low. Let's see. The acute acalculous cholecystitis is relatively uncommon but well recognized cause of inflammation of the gallbladder in the absence of gallstone. It may occur secondary to opportunistic infection, gallbladder ischemia, hypoperfusion in the immunocompromised cases. Then acalculous cholecystitis is less common in the adult than in children, but adult population it tend to affect men more frequently than the women, and it is frequently seen in the surgery and trauma. Its incidence mixed critical care population generally low, but figure rise sharply in the trauma patient. Trauma patient, the high injury severity score more than 12 who are tachycardic, have received blood transfusion, risk of developing acalculous cholecystitis, therefore should be monitored ultrasound. Acalculous cholecystitis may cause microvascular changes associated with several vasculitis, including primary antiphospholipid syndrome, which also managed in anticoagulant rather than the cholecystectomy. So SLE, your HS purpura and other vasculitis, steroid treatment may be sufficient treatment provided initial and there is no initial perforation. So you can use low dose steroid if there is a no acalculous cholecystitis causing perforation. Mortality is up to 50 to 85% without treatment. Clinical presentation often non-specific, resulting late diagnosis, severe complications such as gangrenous gallbladder, gallbladder perforation, abscess formation, ascending cholangitis, peritonitis, and sepsis. So these are the question. We have completed 5 topics in the GI. Among that's most important 3 topics: the acute liver failure, upper GI bleed, and the acute pancreatitis. You have to read all the areas and all the question related to these 3 chapters, and please follow the Farz Academy question which is given in the our LMS system, and follow our previous lecture also. You will definitely get some confidence, and you will definitely will be successful. So thank you all. And day after tomorrow, I will take 2 domain. One is the nutrition, and other is what is there, Sana?
So there is one more domain that we will be covering, and aspirants also. Tomorrow also we have a session with Dr. Shraddha Pathakar ma'am at 7 p.m. And be assured that all of this recording you will be get in your portal. Thank you, everyone. Thank you, sir.
Thank you.
Hi,
Good night.
can I ask before you go?
Yes,
Yeah.
yes, please.
Um, the difference between the K type, I didn't get that. The K type and the types of questions.
Yeah. So, ma'am, then in EDIC, there is a 2 type question, K type and A type. A type means the single base answer, and K type means there is a true and false. So A type single based answer where you will have a 5 option or 4 option. You have to choose the correct option. If you choose the correct option, you will get the full marks, 4 marks. Or if you choose the wrong option, you will get the 0. There is no negative marking. In K type, there is a 5 or 4 option. If you do the right, true and false, if you make the right things, the three option, then you will get half marks. If you do the 4 option correct, you will get the full marks. Or if you do the less than 3 option correct, you will get 0. Okay.
Thank you so much. And is
And
it labeled? Do you know,
yeah,
is it labeled to say you are now answering type A question, type K, or do you have to figure it out yourself?
yeah, type A is not very difficult, but type K is really difficult because you have to know the whole about your subject. So depth of knowledge judged by your type K question. And remember, this is a exam where there is no cut-off marking, but the pass marking is a percentile basis. So it is depend upon the how difficult paper. If the difficult paper, usually percentile, the pass percentile will be 60%. If you easy paper, then pass percentile will be higher. So 65 to 68%. So that's why it's not matter how difficult paper or how easy paper. You target at least 70 percentile, then you will be passed. And
Eh,
there is a no negative marking, so all A type question you will give your answer
Thank you
because
so
there is
much.
no negative marking.
Thank you.
Right. Okay.
Thank you, sir.
Good night.
Good night, everyone. We'll be seeing you tomorrow.